I'm Dr. Keith C. Ferdinand, the Gerald S. Barrison Chair in Preventive Cardiology at Tulane University School of Medicine and Professor of Medicine. And today we're going to continue our series of ACC practical tips. We're going to discuss quick tips to improve patient adherence. And it's my pleasure that we have a presentation, very short, from Dr. Yvonne Commodore-Mensah, PhD, MHSRN. Yvonne has done a wonderful amount of work related to blood pressure, patient adherence, and community programming. How you doing, Dr. Commodore-Mensah?
I'm doing very well, Dr. Ferdinand. Thank you so much for the introduction, and thank you to the ACC for inviting me to present on quick tips to improve patient adherence. I have no disclosures. So the topic of discussion today is adherence, but in the context of hypertension management. A lot of what we're going to talk about today extends to other conditions. So we know that hypertension is a major public health and clinical challenge. The 2017 ACC-AHA guidelines are used to define the cutoffs for diagnosing and treating hypertension. And so using the 2017 guidelines, we know that 47.3% of American adults, or almost half of US adults, have hypertension. But we also know that there are sex and racial and ethnic differences in the prevalence of hypertension. We know that males have a higher prevalence of hypertension than females. Among males, Black males have the highest prevalence of hypertension. And among females, Black females, again, have the highest prevalence of hypertension in the US. A unique aspect of the 2017 hypertension guidelines is that treatment for hypertension is not only based on blood pressure level, but also on atherosclerotic cardiovascular disease risk, but with consideration of the patient's preferences, shared decision-making, and a team-based approach to assess the risk-benefit ratio in deciding to initiate therapy or intensifying treatment. So some patients with hypertension may appear resistant to combinations of antihypertensive drugs, and this may prompt referrals for specialist care, including expensive investigation for secondary causes of hypertension, in conjunction with increasing the dosage of therapy, as well as non-drug therapy. However, uncontrolled hypertension in the context of antihypertensive treatment may not always be resistant hypertension. In some cases, non-adherence may be the culprit. So a scientific statement by the American Heart Association has noted that the diagnosis of resistant hypertension requires assurance of antihypertensive medication adherence, as well as the exclusion of the white coat effect. So what exactly is patient adherence? So one of the definitions out there is that it's the extent to which a person's behavior that includes medication taking or lifestyle changes, which is integral to blood pressure control, corresponds with agreed upon recommendations from a clinician. And so the former Surgeon General is credited with saying drugs don't work in patients who don't take them, end quote. But we have to acknowledge that sometimes there are reasons why patients are not taking these medications, and we have to understand what those reasons are. And so there are three major phases of medication adherence. One is initiation or failure to medication non-adherence. So one is initiation or failure to begin treatment. The second is implementation or incomplete dosing. And the third is persistence or continuation of treatment. So in all of these three phases, a patient may be non-adherent for a number of reasons. So exactly how common is non-adherence? So up to 12% of patients never actually fill their initial prescriptions. And in terms of non-persistence, rates of about 30 to 80% in the first year after initiation of therapy has been reported. And so this statistic is shocking. Up to half of your patients with antihypertensive meds may stop taking them within the first year, right? And so that is really concerning. And 50 to 80% of them may be non-adherent to therapy. So how do we know if a patient is adherent? There are a number of ways to assess adherence. And so there's detection using quantitative assessment, but that is also particularly difficult. It's not a perfect task or method to assess for adherence. So using unstructured self-report, asking patients to self-report their adherence may not be entirely accurate. We can also administer a scale such as the Hill-Bone Medication Adherence Scale or the Moriski Scale. We can also engage in direct observation. It can be another option, but in the context of chronic disease management, that may not be practical. But there's also biochemical detection of drug levels, which also has limitations in terms of practicality and cost. Another consideration is that there are special populations and risk factors for non-adherent. Some of your patients may be non-adherent for a number of reasons. So there's sociodemographic factors, so health literacy may be one of them, poor healthcare access, patients who are uninsured and who cannot afford the out-of-pocket expensive for therapy may be non-adherent to treatment. But there are also therapy-related factors that clinicians can do something about. They include complex medication regimen, side effects, but also the therapeutic duration. We also know that there are healthcare system factors. The cost of therapy, right, may also be prohibitive for some patients. Lack of clinician knowledge in terms of how to assess adherence, how to talk to patients about adherence are also challenges or barriers to adherence to therapy. But we also know that there are patient level factors. So patients may hold certain health beliefs about taking medications. They may also be experiencing side effects from therapy. And we have to ask questions to understand why they are not taking their medications and address those concerns. But there are also condition-related factors. So one of the challenges with hypertension management is that it's a silent killer. So when patients are being adherent to their therapy, they can't really tell because they don't feel any better, right? But we can use several strategies to encourage them to continue to be adherent to their therapy and prevent cardiovascular disease, prevent stroke, and the other costly complications of uncontrolled hypertension. So we also know that adherence is a multifactorial issue, and so the strategies that we implement to address non-adherence are also multifactorial in nature. But I want to focus your attention on the middle column of the slide. So in terms of clinician-related factors, there are things clinicians can do, including patient education, right? So patients need to be educated about why they're taking the treatment, for how long, how many times a day, what are some side effects that they can anticipate. Clinicians can also consult with other clinicians, pharmacists. So community pharmacists are partners that we should engage in the process to improve adherence. Clinicians can also use self-measured blood pressure monitoring to encourage patients to monitor their blood pressure, engage in self-management to reduce their blood pressure. So because I said earlier that hypertension is a silent killer, it helps when patients have a blood pressure monitor at home and can see the evidence of their adherence to therapy. If they know they're taking their medications as indicated and their blood pressure is lowered, it encourages them to continue that positive behavior. So I'd like to leave you with 5 teaching points for today. First, we have to earn our patients' trust to understand why they are not being adherent to therapy. We, secondly, have to engage in shared decision-making. The 2017 guidelines stress the importance of shared decision-making, and this is where the clinician and the patient come together to talk about the treatment options and decide on what works best for the patient. Third, we have to practice team-based care, engage community pharmacists and other team members to understand the reasons for non-adherent. Fourth, we have to communicate collaboratively. If you're judgmental towards the patient, they're likely not going to be honest about their adherence to therapy. And lastly, reducing complexity. Unfortunately, we know that a lot of patients have complex regimens, so we can simplify therapy in order to improve adherence. I'd like to thank the ACC for this invitation and thank you for your time and attention.
Dr. Commodore Mensah, you gave us a wealth of material specifically related to adherence and hypertension. What's one take-home point, one thing that you want the audience really to focus on as they try to improve adherence in their patient populations?
If I were to pick one thing, I would say keep it simple. Make it simple. We know that adherence improves when a patient's regimen is simplified, right? So, for instance, switching to a single pill combination therapy, that reduces blood pressure. It improves adherence to antihypertensive therapy.
Thank you so much. We've been speaking with Dr. Yvonne Commodore Mensah on adherence to therapy and look forward to more programs from the ACC.